There is a condition that affects an estimated 700,000 older Americans. It causes memory loss, confusion, trouble finding words, trouble walking. Put a person who has it in front of you and they look, in every way that matters to a worried family, like they have Alzheimer's disease. It is not Alzheimer's disease. In many cases, it can be treated, and fewer than 1 in 5 of the people who have it have ever been told they have it. That is number 1 on this list, and I will get to it. I am Dr. Patterson, 15 years of practice, and I want to be careful with you today because this subject deserves care. If you are watching this, there is a decent chance somebody in your life has started saying the word, maybe about your mother, maybe about your husband, maybe about you, and maybe you have not told anyone yet that you have noticed it yourself. You have lost the thread in a conversation. You have stood in a room and not known why you walked into it. You have started writing things down that you never needed to write down before, and you have started dreading the moment somebody notices. So let me say the honest thing first, before anything else, because I am not going to sell you false hope. Most of the time, it is what they said it is. Alzheimer's disease is real, it is common, and no video is going to make it not so. If someone you love has it, I am not standing here telling you they secretly do not. But here is what 15 years taught me, and it is the reason I am making this. A handful of conditions where dementias face, exactly, symptom for symptom, and they are treatable, and they get missed routinely because the moment a 76-year-old walks in confused and forgetful, everybody in the room has already decided what they are looking at, including, very often, the doctor. Nobody goes looking for the other thing because the obvious answer arrived first. So today I am giving you the 5 that get missed. We count down from 5 to 1, and number 1 is the 700,000 people from the first 30 seconds. But watch for number 3 especially, because number 3 is the one that gets missed most often of all. And the reason is that it does not look like what you think it looks like. Everybody thinks they know what it looks like. Everybody is wrong. And it is one of the most treatable things on this entire list. Before we start, tell me in the comments, has a doctor ever run these tests on you or someone you love? Just yes or no. I read everyone, and I have a suspicion about what the answers will say. And one thing while we are here, everything I'm about to tell you is part of a bigger picture, the small daily habits that quietly decide how these years actually go. I took everything I tell my own patients and put it into one simple plan. If you want it, the link is right there on your screen whenever you are ready. Now, let me explain why this happens at all, because the reason will make you angry, why this gets missed. Here is the thing nobody tells you about how a diagnosis actually happens. Your brain is not a very original organ when it comes to distress. It only has so many ways to tell you something is wrong, whether the problem is a vitamin, a hormone, a medication, a mood, or fluid pressing where it should not be. The brain's complaint comes out sounding the same. Memory goes, attention goes, words go, processing slows, balance gets uncertain, personality flattens. That is not 5 different pictures. That is one picture with 5 different causes underneath it. And now think about how the average appointment actually goes. A 12-minute visit, a 76-year-old comes in with an adult daughter who is frightened. The daughter says the word before the doctor does. We think it might be dementia. The doctor is already behind. The picture matches. Everybody in the room agrees. And a diagnosis of exclusion, which is what this is supposed to be, meaning you rule the other things out first, quietly becomes a diagnosis of assumption. Here is what makes me angriest about it. The tests that catch most of what I am about to show you are cheap. Some of them cost a few dollars. A vitamin level, a hormone level, a conversation about medications that takes 4 minutes. And the difference between running them and not running them can be the difference between someone getting their life back and someone being moved into a facility. Nobody is being negligent. The system is built for 12-minute visits and pattern recognition is exactly what fails here, because the pattern is a lie. So here are the 5. Let us start at number 5. Number 5, your thyroid. We start with the simplest one, and the one that has the cheapest test on this entire list. Your thyroid is a small gland in your neck, and it sets the speed of everything. Every cell in your body takes its tempo from it. When it slows down, a condition called hypothyroidism, everything slows down with it, and that very much includes your brain. Here is what an underactive thyroid looks like in a person over 60. Thinking gets slow and foggy, memory phrase. Words go missing mid-sentence. Exhausted no matter how much you sleep. Depressed or flat or just not quite there. Cold all the time. Constipated. Slow, deliberate movements. Now read that back and ask what a family sees. They see someone who has gotten old. They see the beginning of something terrible. And it is far more common in older adults than most people know. And it is more common in women, and it very often arrives with almost nothing that looks like a thyroid problem. No lump, no obvious sign, just the slow dimming of a person. The test is a blood test called TSH. It costs almost nothing. Every lab on earth runs it, and when it comes back low and you treat it with a cheap daily pill people have been taking safely for decades, the fog can genuinely lift. So here is number 5, and it is short because it is simple. If you or someone you love is being evaluated for memory problems, ask, has anyone checked the thyroid? It is one line on a lab slip. Number 4, your medicine cabinet. Number 4 is the one I have talked about before, and I am going to keep talking about it until it stops being true. There is a class of medication called anticholinergics. That is a long word for one simple idea. They block a brain chemical called acetylcholine. And acetylcholine is the messenger your brain uses to lay down new memories and stay alert. As you age, your brain makes less of it and leans harder on every bit it has left. So a drug that blocks it lands far heavier on a 70-year-old brain than a 30-year-old one. Here is what makes this so easy to miss. These are not exotic drugs. They are the most ordinary things in your house. The pink antihistamine you take to sleep, certain bladder medications for an overactive bladder, some older antidepressants that get handed out for nerve pain and sleep, certain muscle relaxants, some stomach medications. Not one of them announces itself. Nobody hands you a pill and says, "This may dim your mind." You got it for your allergies. You got it for your bladder. A doctor prescribed it and a pharmacy filled it, so how bad could it be? And here is the part that turns a small problem into a large one, the burden stacks. One of these might cause a barely noticeable dip, but a person takes an antihistamine every night, a bladder pill every morning, and something for nerve pain. 3 prescriptions from 3 different doctors, and nobody has ever added up the total. That is called anticholinergic burden, and the research linking a high total burden to cognitive decline and dementia risk in older adults is genuinely substantial. I made a whole video on the specific drugs, and I will link it because it deserves more time than I can give it here. What I want you to take from number 4 is one action, and it is free. Put every single thing you take in a bag, the prescriptions, the over-the-counter pills, the supplements, all of it, and take the bag to your pharmacist. Ask them one question. Can you add up my anticholinergic burden? There are scoring tools that do exactly that. Pharmacists are wonderful at this. It costs nothing. And never stop a medication on your own. Never. Some of these are genuinely dangerous to stop abruptly. This is a conversation, not a decision you make on a Tuesday. Number 3, depression. Here is the one I told you to watch for, and I need you to actually listen, because this is the one that gets missed most. And the reason it gets missed is that everybody in the room, the family, the patient, and often the doctor, thinks they already know what depression looks like. They think it looks like sadness, crying, talking about not wanting to be here. In an older adult, very often, it does not look like any of that. Late-life depression frequently arrives with almost no sadness at all. What it does instead is slow everything down. Concentration goes, memory goes, genuinely goes. This is not imaginary. They really cannot retrieve it. Words come slowly. Interest drains out of things that used to matter. Movement slows. Someone stops doing the crossword, stops calling their friends, stops caring about the garden, and sits. Now watch what a family does with that. They do not think he is depressed, they think he is going, and they are grieving someone who is sitting in front of them. It has a name in the old literature, pseudo-dementia, and it is a bad name because it implies the memory problem is fake, and it is not fake. Put those people through cognitive testing, and they genuinely do poorly. The difference is not that they are pretending. The difference is why. There are some tells that a good clinician looks for, and I want you to know them. A person with depression will very often tell you their memory is terrible. They will complain about it, in detail, at length. A person with Alzheimer's very often will not. They will minimize it or not notice, and it is the family who brings it up. Depression tends to come on over weeks or a few months, and people can often tell you roughly when it started. Alzheimer's creeps in over years, and nobody can date it. And when you test someone who is depressed, you get a lot of, I don't know. A giving up before they try, rather than the confident wrong answers you tend to get with Alzheimer's. None of that is a diagnosis you make at home. But it is the reason a real evaluation includes a real conversation about mood, and a shocking number of them do not. And here is why this is number 3 and not number 5. Think about who is sitting in front of you, someone over 60, and if you look at the last few years honestly, a spouse died, friends died, they stopped driving, they retired from the thing that told them who they were, their body started refusing them. Their world got smaller, room by room, and everybody around them called that aging and expected them to be fine with it. Of course they are depressed. What is remarkable is that we find it surprising, and it is treatable. Genuinely, reliably treatable, with therapy, with medication, with getting a person back in contact with other human beings. And when you treat it, the fog can lift, and the memory can come back, and people are astonished because they had been told this was the beginning of the end. Quick pause, because this is the natural spot. If nobody has ever explained to you that depression can wear this disguise, tap the like button and subscribe. It honestly helps this reach families who need it. And tell me in the comments if this one landed for you. I suspect it will land for more of you than any other. Now back to the countdown. Number 2, vitamin B12. Number 2 is the one I have talked about before, and it earns a place here because of a specific thing it does that no other item on this list does. B12 maintains the myelin sheath, the insulation wrapped around your nerves that lets signals travel fast and clean. Strip that insulation, and the wiring starts misfiring. And what that looks like from the outside is memory problems, confusion, trouble finding words, personality changes, numbness and tingling in the hands and feet, balance going, unsteadiness on the stairs, and exhaustion that sleep does not touch. Every single box that a family ticks off when they decide someone is going. And after 60, this is not rare. Absorbing B12 from food takes a lot of machinery. You need real stomach acid to release it from the protein it is bound to, and a specific carrier protein to get it across. And after 60, that machinery fails quietly. And a lot of the failure is caused by things sitting in your own medicine cabinet. If you take an acid-reducing medication for heartburn, and millions of people over 60 have taken one every day for a decade without ever revisiting it, you are shutting down the exact acid you need. If you take metformin for diabetes, it is well documented to lower B12 over time. Stack those, and you have a person eating a perfectly reasonable diet and absorbing almost none of it. Here is the detail that matters most, and almost nobody explains it. Ask for the methylmalonic acid test, not just the B12 level. A standard B12 can come back looking acceptable while you are already deficient at the tissue level. That second test catches what the basic one misses. Ask for it by name, and it is not a magic wand. Caught early, people can recover substantially. Left for years, some of that nerve damage becomes permanent, and I am not going to pretend otherwise. Time is the whole game, which is exactly why the test being cheap and nobody running it is such an infuriating thing. Number 1, normal pressure hydrocephalus. And here is number 1, the 700,000 people. And I would bet almost nobody watching has heard of it, which is precisely the problem. It is called normal pressure hydrocephalus. And I know that is a mouthful, so forget the name and hold on to the idea, because the idea is simple. Your brain sits in fluid. That fluid is made continuously, it circulates and it drains away. It is a plumbing system, and in some people, as they get older, the draining stops keeping up with the making. The fluid slowly builds, and the chambers inside the brain swell and press outward on the brain tissue around them. That is it. That is the whole disease. It is not a degeneration. It is not plaques. It is not the brain dying. It is plumbing. And here's what it looks like, and clinicians have an unkind little phrase for the three signs: wet, wacky, and wobbly. Trouble with the bladder, trouble with thinking, and trouble walking. Now here is the tell, and this is the single most useful thing in this video. In normal pressure hydrocephalus, the walking usually goes first. That is backwards from Alzheimer's, where memory leads and the walking holds up until much later. In this condition, the feet go first, and they go in a very particular way. People describe it as feeling like their feet are stuck to the floor or glued down. It is sometimes called a magnetic gait, short, shuffling steps, wide stance, terrible trouble turning around. They have to turn in several small steps, like a person on ice, and they fall. So watch what a family does with that. They see a shuffling, unsteady, confused, forgetful person over 70. They think Alzheimer's, plus he has gotten unsteady, poor man. Nobody ever thinks, what if the walking is the clue, and it came first, and it means something? And here is why it is number one, because it can be treated. A neurosurgeon can place a shunt, a thin tube that drains the excess fluid away, and in the right patients, people improve, sometimes dramatically. Now I am going to be honest with you the way I always am, because this is exactly the place where a video like this could lie to you. The walking improves the most reliably, the memory improves less reliably, and the longer it has gone on, the less comes back. Not everybody is a candidate. There is a testing process to work out who will benefit, and it is brain surgery, which carries real risk. This is not a miracle, and I will not sell it as one, but fewer than 1 in 5 people who have this have been told they have it, which means there are hundreds of thousands of people in this country right now, sitting in a chair, being cared for, with a diagnosis of Alzheimer's on a chart, who have plumbing. If the person you love got unsteady on their feet before their memory went, if their feet seem stuck to the floor, that is worth a conversation with a neurologist. Say the words to them. Could this be normal pressure hydrocephalus? A brain scan can see it. It is one question. 3 more quickly. Before I tell you about Gerald, 3 more that deserve a mention because they get missed too. Sleep apnea. If someone snores heavily and stops breathing in the night, their brain is being starved of oxygen dozens of times an hour and never reaching deep sleep. It shreds memory and attention. It is common, it is measurable, and it is treatable. A slow bleed after a fall. If someone fell, even weeks or months ago, even a small fall they laughed off, and then started declining, blood can collect slowly between the skull and the brain. It is called a subdural hematoma. A scan finds it. A surgeon can drain it. Sudden confusion is different. If someone's thinking changes over hours or a couple of days, that is not dementia at all. That is delirium, and it is an emergency. Often an infection, often a urinary infection in an older adult, sometimes a medication, sometimes a stroke. Dementia takes months and years. If it arrived this week, do not wait. Go. Gerald. Let me tell you about someone I will call Gerald. He is a blend of several patients I have cared for, so nobody's privacy is on the line, but I have watched this go both ways, and that is exactly why I am telling it. Gerald was 76, retired schoolteacher, and his family had already had the conversation. They had toured 2 facilities. His daughter had a folder. What she said to me, and I have heard this sentence more than once, was, "It started with his walking, but that was just his knees. His feet were stuck to the floor. He took 8 small steps to turn around in a doorway. He had fallen twice. And yes, his memory was going, and he had started having accidents, and the family had done what any loving family would do. They had assembled those 3 facts into the diagnosis everybody has heard of. Nobody had asked which one came first. Wet, wacky, wobbly. and wobbly had been first by about a year. He had a scan. He had the workup. He had a shunt. Now, I am going to be honest with you about what happened, because I always am. Gerald did not walk out of there as a 50-year-old. His memory came back partially, some of it, not all of it, and that is exactly what I would have expected, because it had been going for 2 years, and time takes its toll, but his walking came back substantially. The accidents largely stopped. He went home. He stayed home, and the folder went in a drawer. I want to be careful here, because I have also sat with families where we ran every one of these tests, and everything came back clean, and the answer was the one they were afraid of. That happens more often than the Gerald story does. Far more often. And when it does, the testing was still worth it, because they stopped wondering. They stopped lying awake, asking whether somebody missed something. They could put their energy into the years they had instead of into doubt. That is what these tests buy you. Sometimes they buy you your father back, and when they do not, they buy you peace. Both of those are worth a blood draw. The honest caution. Before I let you go, the part I would say in my own office, and I mean every word of it. Most dementia is not reversible. I said it at the start, and I am saying it again at the end, because I refuse to be one more voice on the internet selling desperate families a fantasy. Alzheimer's is common, and it is real. This video is not me telling you your mother does not have it. It is me telling you to make sure somebody checked before everyone agreed. Do not use this to delay a real evaluation. If someone is declining, the answer is to get them seen properly by someone who does this work, not to run a home checklist and wait. Early evaluation matters no matter what the answer turns out to be. Never stop a medication because of a video, including mine. Number 4 is a conversation with your pharmacist and your doctor, not a decision you make tonight. Some of those drugs are dangerous to stop suddenly, and if the change happened this week, stop watching and go. Today's confusion is delirium until proven otherwise, and it is an emergency. What I am actually asking for is small. Walk into that appointment and ask for 4 things by name. A TSH for the thyroid, a B12 with methylmalonic acid, a real conversation about mood, and a pharmacist review of every single thing in the cabinet. And if the walking came before the memory, say the words normal pressure hydrocephalus out loud to a neurologist. That is it. That is the whole ask. It is cheap, it is safe, and it is the difference between a diagnosis of exclusion and a diagnosis of assumption. Recap. So, there they are, 5 things that wear dementia's face. Number 5, your thyroid, 1 line on a lab slip. Number 4, your medicine cabinet, the burden nobody adds up. Number 3, depression, which in an older adult very often does not look like sadness at all, and is the one missed most. Number 2, B12, and ask for methylmalonic acid, not just the level. And number 1, normal pressure hydrocephalus, the 700,000 people, where the feet go first, and fewer than 1 in 5 has ever been told. And here is what I want you to carry out of this, not false hope. I have been careful with you today for a reason. What I want you to carry is a question, and the question is this: did anybody actually check? Because a diagnosis of dementia is supposed to be a diagnosis of exclusion. It is supposed to mean somebody went looking for these things and did not find them. And far too often, in a 12-minute visit, with a frightened family who already said the word, it is not exclusion at all. It is agreement. And nobody in that room is doing anything wrong. It is just how it happens. You are allowed to ask. You are allowed to be the person who says, before we accept this, did we check the thyroid, the B12, the mood, and the medicine cabinet? And did his walking go first? That is not being difficult. That is being the one person in the room who did not assume. Now, there is one more thing I have to tell you, and it may be the biggest of all. Because when researchers went looking for the single largest preventable risk factor for dementia, the one thing that across whole populations moves the numbers more than anything else we can actually do something about, the answer was not in the brain at all. It is not a vitamin, it is not a drug, and there is no blood test for it. It is sitting on the side of your head, almost nobody over 60 gets screened for it, and the trial evidence that treating it slows cognitive decline in at-risk older adults is real, and it is recent. In my next video, I will show you exactly what it is. I will put it right here on the screen. I am Dr. Patterson. Ask the question. I will see you there.